أقدر أبدأ؟ تسمعوني الآن ولا؟
وعليكم السلام، نسمعك خليفة.
طيب بسم الله. نبدأ بسم الله. أبدأ إن شاء الله في multiple valve disease. As an introduction of this topic, the definition of multiple valve disease is pathological changes in the cardiac valve requiring surgical correction of more than one valve, and the causes of this disease, either rheumatic heart disease or degenerative valve disease, or infectious endocarditis, or other causes. For valve dysfunction, usually there is a primary or secondary cause of valve dysfunction. Primary is the disease process is affecting the valve itself, but for the secondary one is due to other cause, or there is an underlying cause leading to this valve disease, either cardiac enlargement or pulmonary, due to cardiac enlargement or pulmonary hypertension. And there is points affecting our management in multiple valve disease. The first one is the underlying cause of secondary valve disease, and the other one is anticipate the response and anticipate the response to correct this primary, and consequences of the disease valve in the left or right ventricle geometry and function. All the 3 points will be affecting our management. Then, as a history of multiple valve disease, the first triple valve replacement done in 1960, and the 4 valve replacement done in 1992. And you can see when started each institute and each event, which start in 1952, the stage mitral, then tricuspid commercialotomy. In 1992 started in Mayo Clinic, where they have been done simultaneously quadruple valve replacement. For epidemiology for multiple valve disease, multiple valve operation is 15% of all operation in the cardiac valve, and 80% of those patients involving the aortic and mitral position, and 20% of operation it's related to replacement of mitral and tricuspid, either with or without aortic replacement. And there is really a combination of aortic and tricuspid disease. And you can see here in the table the prevalence of multiple valve cardiac replacement according to the institute, and the percentage of all valve surgery. Mostly, you can see the mitral involved in mostly all the procedures. Then we are going to for pathophysiology of multiple valve disease. We'll start with the valvular regurgitation, as they started in our reference. It will be primary or secondary valve regurgitation. The primary one, as we speak before, it's happen where the affecting primarily the disease process affecting primarily on the valve. Secondary or functional, it's a result from changing in ventricular morphology, and yeah, changing in ventricular morphology, which is expected to be improved with repair or replacement of the primary disease valve, or if we manage that, or expected to not be improved. Even if we repair the primary lesion, we have to repair or replace the secondary disease.
خليفة
تفضل.
يعطيك العافية. I want first of all welcoming Dr. Kabir and Dr. Mohammed Al-Shaydan. They are with us in the academic activity. Today we will discuss multiple valve disease. Will be presented by Khalifa. Then preoperative valve surgery by Dr. Amjad Barnawi. Then we will have a journal club to discuss restrictive versus liberal blood transfusion and cardiac surgery. In the screen, you can see there is a mute in the same screen for Dr. Shabir and Dr. Shaydan. If you want to participate, you just unmute, then you can speak directly. Once you finish, you can mute again, and according to what you like. Also, there's a chat button that also we can participate through it.
Yeah, thank you, Dr. Haitham. Sure. Yeah, let him finish the presentation, and we'll see. Or in between, if there is any issue, or where we can, add or elaborate some more things, we'll see. So let Khalifa finish his presentation. I think so.
Okay, thank you. خليفة.
Sure. أهلا.
حاول ترفع صوتك شوية بعد إذنك.
صوتي مو واضح؟
يعني كذا أحسه بعيد، معلش. اتفضل.
طيب كذا. ألو.
تفضل خليفة، أبدأ.
For the primary aortic valve disease, I'll start with the primary aortic valve disease with the secondary mitral regurgitation. The isolated aortic valve lesion can be caused secondary regurgitation of the mitral valve, and rarely causing tricuspid valve. How that happen? It will happen by severe aortic valve stenosis, leading to 67% associated with mitral valve leakage. And we have two categories: either the mitral valve will be normal structure, or the mitral valve will be abnormal structure. If the mitral valve normal structure, the regurgitation expected to be improved with once we are relieve the LVOT obstruction. So once we replace or repair the aortic stenosis, this regurgitation will be improved. If it's especially if it's mild, it will resolve almost completely, and it's a result from decrease in intraventricular pressure and ventricular remodeling. This is how the regurgitation is happening due to these two causes. And the severe one still will persist the regurgitation even if we replace the aortic stenosis disease. So we are requiring for mitral valve annuloplasty. For the structurally abnormal mitral valve, we have to repair or replace the mitral valve along with the aortic valve, and they are reporting moderate MR has an adverse impact on survival in elderly patients. So we are going to replace the mitral valve even if it's secondary. For the investigation, we have to have a TTE, transthoracic echo, where we can define the which one the primary etiology and which one the secondary one. And the transesophageal echo, we can also use it, which is the best image and giving us a better resolution, especially intra-op. We can use TE, so we should be employed in all patients having a valve repair or replacement during surgery. And for the ventriculography and right ventricular angiography, the first one just for quantify the left atrioventricular valve leakage, which is not commonly done now, and the right ventricle is also for quantify the degree of tricuspid. For the second valve physiology, it's tricuspid valve regurgitation, which is secondary to any other valve disease. Commonly is associated with rheumatic mitral valve stenosis, and the exact cause of tricuspid regurgitation is unknown. And tricuspid valve annular dilatation in those severe TR usually asymmetry. The dilatation of the annulus in the tricuspid usually asymmetry. There is most large occur at the free wall of the right ventricle, and little dilatations will occur in the septal leaflet. So the septal leaflet is more fixed than the free wall. And we have 4 scenarios for tricuspid regurgitation as a secondary to other valve disease. The first one, and they are just to manifest or elaborate the cause of secondary tricuspid valve. The first one is tricuspid valve regurgitation secondary to pulmonary artery hypertension and right ventricular dilatation. But even though uncommonly tricuspid regurg in children with the tetralogy of Fallot, where the overriding of aorta and the RP enlargement is not the solo mechanism of this disease, and it's not associated with the tricuspid regurg. So we can depend on this theory first of this scenario, but still we have other than this. The second scenario or the second theory, patients who have had mitral valve replacement for rheumatic mitral stenosis also have a chance to develop regurgitation of native tricuspid valve years after operation. So after we are replacing the mitral valve, by years the tricuspid will develop secondary tricuspid regurg, and many patients have only mild to moderate elevation in pulmonary artery. They claim the progression of immunological process in the rheumatic valve disease that will lead to severe tricuspid regurg. And can be classified the secondary mitral regurg and tricuspid regurg as a mild and moderate and severe. The mild tricuspid don't have a clinical sign or symptoms, right heart failure. In this situation, we don't have required for intervention. If the regurgitation is significant, second one is regurgitation is significant, and we don't have right symptoms were controlled by medical treatment, we have to just doing repair in this situation, either Vega suture annuloplasty, we will speak about it later, and partial ring annuloplasty also. For the third one, severe secondary tricuspid and the clinical evidence with the right heart failure, we have to have either concomitant ring annuloplasty or even tricuspid valve replacement with the primary disease, for sure. The third scenario, the third condition, the degree of pulmonary hypertension may influence the surgical management of secondary tricuspid valve regurgitation. So after mitral valve surgery without operation in tricuspid, they have been reported there is a study, they divide the patient to two groups, the patient who have severe pulmonary hypertension and the other one who have only moderate pulmonary hypertension. But by the way, the moderate pulmonary hypertension, they were have more right ventricular heart failure, and both of them, they did not operate on tricuspid, and the result showing regression in severe pulmonary hypertension, regression of tricuspid regurg, and 28% completely resolution without any intervention. For moderate pulmonary hypertension, also they continue to have a tricuspid regurg. So if we claim the pulmonary hypertension is the only mechanism which can affecting the tricuspid regurg, through this study, proven opposite. So the difficulty with the management of secondary tricuspid due to there is heterogeneity in patient disease and also in surgical procedure. Let's say in rheumatic mitral regurg, the instance of late severe tricuspid regurg is 68% in 30 years follow-up of mitral valve replacement. For ischemic MR, late secondary tricuspid regurg is 74% in 3 years follow-up of repair of ischemic mitral regurg. And there is a risk factor for tricuspid regurg progression. First one is elderly and female gender, and also rheumatic etiology and atrial fibrillation and the absence of major procedure. All 5 risk factors will we have to anticipate the tricuspid regurg will progress if we did not interfere. And correction of moderate or severe tricuspid regurg at the time of surgery of rheumatic mitral valve disease is indicated to prevent symptoms associated with tricuspid progression, but less clear for the long-term survival. So we don't know about the long-term survival, but sure it will improve the symptoms. fourth scenario, or the fourth situation is the mitral valve prolapse with secondary tricuspid regurg. Moderate or less functional tricuspid regurg, which is mild, does not progress following repair of leaflet, which is prolapse, as aggressively when we compare it to rheumatic. In rheumatic, they will progress even years after mitral replacement or repair. But here, no, they are not progressing. Mitral valve surgery before the development of, we have to do the mitral valve surgery before development of left atrial dilatation and pulmonary hypertension, because these two factors will increase the tricuspid regurg to progress. And indication for concomitant tricuspid valve repair, moderate or moderately severe or severe tricuspid regurg. So this is the first one. The second one is right-sided heart failure with moderate or severe tricuspid regurg. And third one, moderate tricuspid regurg with one of the following, associated with one of the following: primary tricuspid regurg, or structurally abnormal tricuspid, and dilated right atrium and right ventricle, severe pulmonary hypertension, and atrial fibrillation. Long-term outcome study for prognostic impact of isolated tricuspid regurg confirmed that presence of mild to moderate isolated tricuspid was not associated with the survival difference. And summary for tricuspid regurg secondary for other valve disease, if it's asymptomatic and less than moderate, and secondary tricuspid, not primary, with degenerative mitral disease, unlikely to progress, and or unlikely to have an impact on the survival after mitral valve repair. So in this situation, we will not interfere with the tricuspid. For valve selection in multiple valve replacement, you just attach the photo for mechanical and bioprosthesis valve.
Khalifa,
Yes.
sorry for interruption. I just want to comment kindly. On the indication, you are talking about isolated tricuspid, and also you talked about combined procedure where there is mitral involvement.
Yes.
In guideline, any severe with a concomitant left-sided, you have to do. Now we'll go to the mild to moderate, mild or moderate, because you mentioned only moderate and above.
Yes.
In guidelines, class 2A, to go even with a mild or moderate secondary TR, but giving that you have to have dilated annulus, either 40 millimeter or index 21 millimeter per meter square. Okay, many paper came out recently showing even the benefits of midterm and long-term survival. There is other paper not showing, even in isolated tricuspid, showing survival benefit as well. Yes, I want to add this and to know the number of 40 plus 21 as indexed. And when you have a tricuspid regurg mild or moderate, but you have dilated annulus 40 or index 21, at that time you need to address the tricuspid valve.
Mm-hmm.
I will send you today a longer about this topics as well. I believe I sent it before in the group. I will send it again today.
Okay.
Yes, small comments about what you were mentioning.
Yes, yes.
Dr. Khalifa, you got it? You understand?
I got it. There is
This is an asymptomatic.
use,
Yeah. What he was trying to say you, it is an asymptomatic patient with mild to moderate tricuspid. You can fix it only if the annulus is dilated. Either you can do, as he said, 40 mm, or you can index it 21 mm, or you can just do an intraoperative 70 mm. I just want to add that part. The surgeon just do their own, between the two commissures, if it is 70 mm or more, just fix it if you do not have an echo.
even mild.
Excuse me, can I add a comment here?
Yes.
Yeah, this is Dr. Rashidan speaking. So treatment of tricuspid valve related to the mitral valve, it's actually becoming very interesting topic, because most of the people who were presented with the mitral valve, they will have some degree of tricuspid valve regurg. So before, people used to shy away because they think it's increased the complexity of surgery. But now, I think as in the moderate era of mitral valve operations, most of these patients who have a tricuspid valve, they should undergo a repair. So first of all, you need to know if the patient presented with right-sided heart failure. So how we differentiate between left and right side, this is very important. Usually, if the patient have severe mitral regurgitation, they will not have signs of RV failure, which is pleural effusions, lower limb edema. So if the patient presented to your office or the clinic or inpatient with the signs of RV failure, regardless of the degree of their tricuspid regurgitation, they should undergo tricuspid valve repair. So as you know, if the patient have severe TR undergoing left side valve surgery, this is class 1 indication. There is no brainer about this. It becomes tricky when you go to the lesser degree of tricuspid regurgitation. Here, it depends. If the patient have even a prior history of RV failure, even with this admission doesn't have RV failure, but when the history that the patient have a prior RV failure, this is class 2A, this patient should go for a tricuspid valve repair. And we also depend on annular dimension, as Haytham said. We have also to look at the responsiveness of the patient to the medical therapy, because if the patient have severe tricuspid regurgitation and he is not responsive to the treatment, this is another class 2A for the patient to have tricuspid valve repair. The other thing you need to be aware of the American guidelines, which was published in 2014, and there is another European guidelines, because the European they actually more aggressive with treatment of tricuspid valve regurg than the American guidelines. Thank you.
Thank you.
Thank you, Doctor. Also, Khalifa, you mentioned about maze.
Yes.
For everyone, you in the previous slide, you were also mentioning that the patient, one of the progression or risk factor for progression is not doing maze, because atrial fibrillation by itself, it can lead to dilatation of the right atrium. So when you are doing the maze, you are protecting if it is successful. And now there is a lot of, it is class 1 indication to do maze in patient with atrial fibrillation. But this will be a different topic later.
So to add a comment, and because I have interest in maze, so indication of maze is different by where you're looking for, right?
Right.
If you're looking at American guidelines, there's no class 1 indication for maze because people think it's a complementary surgery. But if you look at the SDS task force, which is a new guideline which was published in 2017, you can see that people have studied this thoroughly about the usefulness of atrial fibrillation surgery. So in my opinion, any patient who's going for a valve surgery that you're going to open the atrium and the guy has an atrial fibrillation, he should undergo maze operation, given that it's not going to increase your complexity and it's not going to increase your mortality rate. For example, if the patient, I actually, most of the patient we're doing now, we're doing double valve with maze procedure, as you know, in our center in King Fahd Medical City. Yes. Unless this patient is coming for a very complex surgery, like I did a case a couple of weeks ago. I redo triple valve, and the atria of this patient was huge. It was like more than 8 centimeters. And I approached this because the guy had a previous left atrial incision. So, and you have to be careful when you do maze in these kind of cases, because if you're gonna open, if you go through transeptal approach and you do maze, you increase your chance of the patient having a pacemaker after surgery, because you will interrupt all the conduction system to the AV nodes.
Mm-hmm.
So as a comment, if you're gonna do maze procedure with the double valve operation, including mitral and tricuspid, you should avoid going through transeptal approach. You should do this through the left atrial approach and right atrial approach, because this will reduce your chance of having pacemaker after surgery. And yes, anybody coming for a double valve operation with atrial fibrillation, guys have tricuspid valve regurgitation, should undergo maze with the ring of the tricuspid valve. I just want to give a comment about De Vega, because Khalifa mentioned that if the guy have a mild,
Yes.
I recommend for you guys, don't use De Vega, because De Vega in multiple series showed very bad results. De Vega should be used only in very, very limited situation. If you don't, if the ring is not available, or if you're not familiar how to do tricuspid valve annuloplasty. But otherwise, we should mainly do a partial ring for tricuspid valve, because this is the most successful repair data and literature. Thank you.
Thank you.
Thank you.
تفضل خليفة.
Okay, I will proceed for the valve selection for multiple valve replacement. Multiple valve replacement, if it's to the left ventricle, we have to have chose from the same class, either mechanical or tissue. Although study shown no reduction in the risk of thromboembolism or valve-related morbidity or late death if we choose any one of them. In respect to tissue valve, had more hemodynamic advantage in comparing to mechanical if we put it in the AV atrioventricular valve, and lower the reoperation rate is reported for patient with two mechanical valve. And for tricuspid valve replacement, use bioprosthesis have an advantage in regard to minimizing the risk of valve thrombosis, but to be used the mechanical valve in case of carcinoid disease. Then now I will start with the surgical methods, and I have 5 situation: aortic and mitral valve replacement, first one. Then aortic and valve replacement with the mitral valve repair. Then mitral valve replacement with tricuspid valve replacement or repair. Then the 4th one is tricuspid valve replacement and pulmonary valve replacement for carcinoid heart disease. The 5th one is triple valve replacement. I will start with aortic and mitral valve replacement for cannulation, then cardioplegia, and procedure. For the cannulation, as we can see here in A, the cannulation site for arterial cannulation to be distal in ascending aorta, just near to the origin of the illuminated artery, because we are planning to do aorta and the mitral. Then the site for venous cannulation is two-stage cannula, single two-stage cannula in the right atrium. And we are using intraoperatively auto transfusion which is routinely to be used in this operation. For cardioplegia, after aortic cross clamp and myocardial protection to be given cold blood cardioplegia through the TAC vent, and just to reach the diastolic arrest, hypothermia, and the cardioplegia depend on how much we are giving, depend on the heart size and the aortic valve competency. Because the heart size with the multiple valve disease, usually the heart will be hypertrophied, so it will require more cardioplegia than regular coronary revascularization. And for the valve competency of the aortic valve, if the aortic valve competent, we can give in the first infusion just 10 ml per kg of body weight. And if there is a hypertrophy, we can give up to 15 ml per kg. And for repetitive infusion, we can give 400 ml each 20 minutes. And it will be directly into the ostia because aortotomy will be part of our surgery. If the aortic valve regurgitant, we have to infuse, especially if it's moderate to severe, we have to infuse directly in the coronary ostia, or we can use a retrograde infusion. Then we will also give it through the ostia again. We have to have emptying the heart by using either TAC vent or reducing the cardiopulmonary bypass rate for temporary. In the procedure step, it will be aortotomy and the aortic valve to be inspected. I will go through the images. Just I will mention them first. Aortotomy, to be inspect the aortic valve, then incision of posterior to the interatrial groove for mitral valve inspection, which is in the left atrium, as Dr. Mohammed mentioned. And the third one is mitral prosthesis implanted, then aortic prosthesis is sewn. After that, de-airing, removal of aortic clamp, then vent removing, and the last one is closure of left atriotomy. This is the first step. We have to have an oblique aortotomy incision into non-coronary cusp. Then aortic valve, if the aortic valve regurgitant, either caused by, we will inspect the aortic valve, and we will define the cause if there is perforation or prolapse of the cusp. Then we have to take in consideration whether or not the mitral valve prosthesis will need it in aortic valve regurgitation. This is the first pathology which we can face it, aortic valve regurgitation. The second pathology we can face it is a severe calcification of the valve, where we have to replace the valve, and we will excite the valve as we see here. And then we will calibrate we are exciting the whole valve, then we have to calibrate the annulus. But we have to keep in mind, once we are calibrating the annulus and there is aortic and mitral valve surgery, the calibration will be changed after implanted the mitral valve, because reduce the circumferential of the aortic annulus after implanting the aortic valve. Then after calibration, we can go for mitral. For the mitral valve, we can go through the left atrium incision in the interatrial groove, and we will expose the mitral valve through this incision. And we will inspect the mitral valve. If it's rheumatic, we have to replace the rheumatic valve, both even aortic and mitral, if the pathology is rheumatic. And for repair in rheumatic, it will progress. The pathology will progress, and the repair will be less durable. So we will not go for repair. And calcification of bypass when the disease is calcification also. For mitral valve repair in degenerative causes, it's good as a long-term result. In anterior leaflet, mitral valve is excised. We'll see here in the image how we can do the anterior leaflet of the mitral valve will be excised. Then we will some surgeon will preserve the anterior leaflet and the cordial attachment that we are seeing here. He's preserving the cordial and the leaflet attachment. Then we will use interrupted matrix with the felt pledget for implanted the valve. After we are finishing from the valve, mitral valve, we will go back to the aortic, and we are going to calibrate it again to make sure it will fit. So we have to have the actual caliber and the one size below it if we need it. Then after that, after implanted the mitral, then aortic valve, we are going to close the aortotomy, and as they mentioned, in 2 layers with for proline. Then we have to do de-airing by CO2 or Valsalva, then using thick vent in the here in the proximally in the aorta for suctioning, and then we will remove the cross clamp. After that, we can remove the vent from the left atrium and this left atrial vent. Then we will close the left atriotomy. This is the last step. For patch here, when we face the small annulus, we can go for enlargement of the aortic annulus with the patch of pericardium. This is the first surgical methods for aortic and mitral valve replacement. Second one is the aortic valve replacement with the mitral valve repair. Intraoperatively, the TE is useful to just to assess the degree of mitral rigor. Then we will moderate, if it's moderate MR and the leaflet, especially it's normal structure, we will do sternotomy, then cannulation, as we explained previously. Then assessment of aortic valve, then we will proceed for mitral. For the mitral, we will go depend on the operative finding, which we will find it. Is it localized prolapse or rupture of chordae? If it's localized prolapse, and this is have been explained before in mitral valve repair, to do triangular excision of segment, prolapsed segment. Then we will repair with continuous 4O suture, and we will support with ring, supplement with the posterior annuloplasty. Here you can see. And for the rupture of chordae of anterior leaflet, we can replace it with the 4O or 5O suture inserted into the papillary muscle, then through the free edge of prolapsed leaflet. This is the repair technique in mitral. And then after that, we
Khalifa, sorry, can I interrupt you for a second here? Okay, so in terms of double valve replacement in aortic and mitral valve, and then aortic valve replacement and mitral valve repair. So the sequence you mentioned is it's okay, but there is a new, actually now people use a new techniques now. Okay, people insert the LV vent through the right superior pulmonary vein as you do it in any valve cases, and then you put it across the mitral valve and you close the left atrium. Okay, then you replace your mitral valve after you finish your aortic valve after you finish your mitral, and then you de-air and you lift the vent across the mitral valve, so it will help in de-airing after surgery. This is one thing I want to add. The other thing, when you do aortic valve replacement and mitral valve repair, you can leave the aortic valve in its place, do the mitral first, and then come back to the aortic valve. Why? Because if you open the aorta and resect the aortic valve, you will not be able to assess the mitral valve, because you need to pressurize the aorta so you can assess the mitral valve. Okay?
Okay.
Thank you.
Dr. Muhammad.
Yes,
Dr. Muhammad, yes. I have a question. You said, I just want to, very interesting. Yes. Very interesting. You said fix the aortic valve and then repair the mitral, right?
No. Leave the aortic valve. Don't touch it. Just leave it in place, and then do the mitral valve, and then come back and do the regular AVR. Because if you take the aortic valve out, then you keep the aorta open, you cannot pressurize the ventricle to test your repair or see what's going on with the valve, you know? So the best thing to do is leave the aortic valve in its place. If you're planning to replace
got it. Yes, you know, if you are 100% sure, like you are replacing the valves, both valves, you know,
yeah, that's different. Yeah.
As has been done by Khalifa, excise the aortic and then go to the mitral, fix the mitral, come back. Okay, if you are, you mean if you are repairing, then better do not touch the aortic valve.
If you have a rheumatic mitral, and rheumatic aortic, and you know you're gonna replace both, then you go with the same sequence. You take the aortic valve, then go replace the mitral, then come back to the aorta. But if you're dealing with a patient with calcified aortic stenosis and ruptured cord, then leave the aortic valve in its place, repair the valve, the mitral, and then come back and replace the aorta. This will give you better chance for repair, because you'll be able to test your valve and see exactly what you need to do.
Yeah, that's fine. Thank you.
Okay, thank you.
Okay. The third surgical method is the mitral valve replacement, and in association with the tricuspid valve replacement or repair. For tricuspid valve regurgitation, it's mainly caused by annular dilatation as a secondary for mitral valve, and the severity is determined by TEE before bypass, and also we can examine by digital exploration of right atrium just before the venous cannulation. We can assess the tricuspid also, regurgitation. Taking in consideration the clinical condition of the patient and the echo finding and intraoperative assessment, all three, if the patient have right-sided heart failure, we will sure requiring tricuspid valvoplasty. If the patient have without right-sided heart failure, tricuspid valve function may improve without direct repair. But as you mentioned, the new guideline, we will repair it. The decision for managing of functional tricuspid valve regurgitation at the time of mitral valve replacement is important. Why is that? Because just the risk of subsequent reoperation is high. The mortality rate will be 25%, and TR will progress in 10 to 15% of patients after rheumatic mitral valve. So we will interfere earlier in the first place. For procedure for mitral and tricuspid, we will. It's an optional, but it's good to have it. It's one GAN catheter, and we will withdraw it from the right heart after during inspection of tricuspid. Then after that, cannulation, IBC and SPC, which is separate venous cannulation, and we will do cardiopulmonary bypass and cardioplegia. Then we will do cave snared. Then after that, right atriotomy. We will inspect the tricuspid, then expose the mitral through the interarterial septum or septal approach, septum approach. Then we will repair or replace the mitral. Then after that, we will do septal incision. We will close the septal incision. I have here the Edward ring annuloplasty and the Vega and for here, if we can see the tricuspid valve, just we have a dilatation of the annulus and failure of coaptation of the valve. Then we are just we are applying the suture around it. This is the Vega, and we will reduce the annular size, and the coaptation will be improved. And we have to take care of AV node in the septal AV.
Sorry خليفة in triangle of Koch.
Okay.
لا أنت بتقول to be aware of the AV node. It's a triangle of Koch.
Yeah, it's a triangle of Koch, but I mean at the side of the septal leaflet, which is triangle of Koch. One of the boundaries of the triangle of Koch is the septal leaflet. Thank you.
So Khalifa, yes. So how do you size the tricuspid ring?
We will size it in between the two trigon. Not the two trigon, sorry.
There are two ways. One way you can take one of the leaflet, the same as the mitral, and see the size. I forgot the other way, right?
Yes, I just do it with the, I just assess the anterior leaflet size and in the mitral between the trigonal and leaflet height. But in the tricuspid, I just do the anterior leaflet height. Just to say in my personal experience, you know, I usually do not measure much of this waste time I just put most of the time 95, 99% 28 size ring. So yes. So it is anterior leaflet height. Yes, I agree with you.
Yes. Okay. The fourth method, which is tricuspid valve replacement and pulmonary valve replacement for carcinoid heart disease. It can be performed without needed for aortic occlusion or cardiac hemiplegia and aortic cross clamp, but we have to take care of we don't have mitral or aortic involvement, and the second one, we don't have a foramen valve, because otherwise, once we are opening the right side, the air will enter into the left system. And the old strategy, they were replacing the tricasp and excising the pulmonary valve. But nowadays, we are doing the replacing both tricasp and pulmonary valve because once we are preserving the when we are having competent valve, we will preserve the right ventricle function. And in the tricuspid replacement, we are just removing the anterior leaflet and associated with the prolonged survival in carcinoid. And sorry, if the exposure is difficult in tricuspid, we can go for a brief aortic cross clamp and doing especially the suture of posterior and septal leaflet. Then we can remove the aortic cross clamp. And we have to have an observation for ECG during taking the incision suture to don't develop the AB block. If we develop that, we have to remove the suture and insert another one just superficial. Here the pulmonary valve replacement, and we are usually inside the inside across the valve annulus, longitudinal incision, and into the outflow of the right ventricle. Then insert the prosthesis valve. Then after that, the anterior part, we will leave it and we will patch it with the pericardial patch, augmented with the closure of PA and the RB. The fifth surgical method, triple valve replacement. I will go just for sequence, then we will go for the conditions. Aortic valve regurgitation, if we have it, we will do aortotomy first. Then we will snare the SPC and IVC, and we will open the right atrium. Then we will excise the aortic valve and calibrate it, the annulus. Then after that, interarterial septum incision, mitral valve repair or replace. Then we will come back to the aorta and implant the aortic valve. But as Hamid mentioned, if we are planning for repair, we will not open the aorta. Then closure of aortotomy and septotomy. Then after that, tricuspid valve can be done without cross clamp and or even prosthesis replacement. Like that, we are finishing almost half of our lecture. Other half, we have 4 conditions and related to affecting multiple valve. We have a rheumatic heart disease affecting multiple valve, and myxomatous and collapsing valve disease affecting multiple valve, senile calcific aortic valve disease with multiple valve involvement, and carcinoid heart disease. Each one we will speak about epidemiology and the pathophysiology, brief, and operative decision making. We will start with the rheumatic heart disease with multiple valve.
Khalifa,
تفضل.
I think we can take 5 minutes break.
Sure.
Okay, so we will resume after 5 minutes. Thank you. خليفة.
السلام عليكم.
السلام ورحمة الله.
السلام.
دكتور تفضل.
السلام.
توني خلصت الاجتماع عشان كذا توي جيتكم اشارككم، معليش تاخرت عليكم. ان شاء الله يكون معكم كونسلتنت اليوم.
معنا دكتور محمد الرشيدان ومعنا دكتور شبير.
ما شاء الله تبارك الله، يعني كويس. يلا لو زهموني الاجتماع الثاني يصير برضو في فرصة. شكرا جزيلا، جزاكم الله خير.
لا ما نستغني عنك دكتور.
الله يكرمك.
في كلمة دكتور ياسر معانا.
ايوه دكتور
ياسر الغنيمي.
شايف هنا اسمه موجود.
ايوه دكتور ياسر الغنيمي معانا برضه.
ما شاء الله تبارك الله. والله هذه الاجتماعات حتجيب لكم كونسلتنت كده اكثر، حتاخذوا احسن ناس، كريم دول كريم في المملكه كلها. وارسلوا الدعوات يا شباب، من جد ارسلوا الدعوات لكل الريزدنت في كل حته وكل الكونسلتنت اللي موجودين. يمكن في يعني مين يكون فاضي ولا يقدر يشارك ولا يكون حتى تخصصه يعني هذا الشيء، او عنده استمتاع يعني، او يحب يراجع معلومات ويتعلم شويه منكم.
إن شاء الله دكتور. We will work on it.
شكرا.
خليفة. You can start if you like.
كيف الصوت الحين يعني؟ أحسن ولا؟
واضح.
ممتاز. تفضل.
بسم الله. Now the second half of the lecture have rheumatic heart disease with multiple valve, myxomatous and prolapsing valve disease with affecting multiple valve, and senile calcific aortic valve disease with multiple valve, and carcinoid heart disease affecting multiple valve. I will speak about epidemiology, pathophysiology, and operative decision making during each disease. For rheumatic heart disease affecting multiple valve, in the epidemiology, if you can see the table here, mostly all the patients with rheumatic heart disease have some element of mitral, almost all the patient, and there is a long-term follow-up for children with rheumatic heart disease, suggested approximately 50% of patients having multivalvular involvement. And rheumatic heart disease can cause valve stenosis or valve regurgitation, as we are seeing in the here, and also sometimes mixed or combined lesion. For the mixed lesion, commonly it's aortic and mitral. The most common combination is aortic and mitral. Then here we can see the classification of patients undergoing valve surgery. The same, the mixed one, it's aortic stenosis and aortic regurg, mitral stenosis and mitral regurg. You can see the total here. Okay. We will start with the first. We have three lesions. We are speaking about one lesion. The three lesions is rheumatic mitral stenosis, MS with AI, rheumatic aortic regurg, and rheumatic mitral stenosis with rheumatic aortic stenosis, and rheumatic mitral regurg with rheumatic aortic regurg. We will speak about pathophysiology first for rheumatic mitral stenosis with rheumatic aortic regurg. We will speak just for isolated mitral stenosis. If we can see, if we have a stenotic mitral valve, we will have high left atrial pressure and will backflow or back pressure into pulmonary, and we will have pulmonary hypertension, and LA pressure will increase, then LA compliance, then pulmonary venous pressure will increase, and we will end by pulmonary artery pressure will be high. In aortic regurg, aortic regurg, we will have a left ventricle volume overload due to regurgitant volume going back to the ventricle. Diastolic dysfunction will occur, and left ventricle end diastolic pressure will be increased, and will give back left atrial pressure, and also the same will have right ventricle pulmonary hypertension. Then in the early phase, if we going for right ventricle afterload increased, then we will go for right ventricle remodeling. But once we have a combination of aortic regurg and mitral stenosis, we'll have decreased cardiac output, and we will have also that in aortic regurg usually we have some specific signs as water hammer pulse and collapsing pulse. All of that will be minimized just because we have an aortic stenosis with it, and that will reduce the left ventricle volume overload. Instead of underfilling the left ventricle due to MS, it will be overfilling due to associated with aortic regurg, and then pulmonary hypertension will be there. So we'll have 4 point cardiac output will be decreased, and the left ventricle volume overload, and instead of MS to be underfilling left ventricle, to be overfilling due to AR and the pulmonary hypertension. For operative decision making in mitral stenosis and moderate or severe AR, we will replace both if we found that intraoperatively, and repair of AR with the calcific extension by pericardium autologous or bovine pericardium. Early result, it's good, but late it will causing late prosthetic replacement. It will be needed just because the valve will develop fibrosis, and preoperatively TEE and intraoperatively TEE, we have to assess the function of aortic valve and degree, and we can assessing that by degree of ventricular filling, and also by the root distension during cardioplegia. Then the second lesion, rheumatic mitral stenosis with rheumatic aortic
stop you here for a second?
Yes, please.
You come back to your four statements.
Here?
No, forward, please. You had, yes, stop here. Did you want us to comment or make questions,
yes,
or shall we wait until the end of your procedure?
You can interrupt me anytime.
So, in general, you should not really make a statement like the first one here, replace both. Many times, mitral stenosis, especially in rheumatic heart disease, we can really manage that with repair many times. Our repair rate is sometimes 70 or 75% of the time. So we end up replacing one valve, the AR, mainly because the results, long-term results of severe aortic regurgitation in rheumatic disease is not good for repair. We have a very high failure rate, especially in a certain group of patients, age group, or in active rheumatic carditis. For the mitral, on the other hand, we have very good success rate, more than 10 years good results. 70% of the patient will not require any further surgery for that repair. So I think this statement is somehow simplified. What's your reference?
This is Lawrence.
Okay. All right, but always keep in mind that yeah, whenever you make a generalized statement, there may be some exceptions, and maybe it's better to ask for the experience. Thank you.
لو سمحت دكتور فريد.
تفضل.
I think there is some new evidence about the repair of rheumatic mitral and almost comparable to the replacement. Am I right? Or no?
Okay, let me just see here. I'm sorry. When you say, again, the statement, you have to qualify that statement. So in our hands, in our population with rheumatic heart disease, I think repair still holds as better. We have, in our population, we looked at the mitral valve replacement. We found many patients come to the outpatient clinic after perfect surgery with INR out of range. 60% of our patients have INR out of range, less or more, and that calls for complications. So if some centers, even in the best centers, I recall even papers from Holland and another one from Canada stating similar results. It's not definitely out of risk to replace the valve with a mechanical valve. With the current valves, tissue valve that we have available, and the less need for anticoagulation, that may be reasonable to consider. But mind you, also the risk of having to reoperate earlier for those patients. So I put that forward because you have to consider your population and see where your patient is coming from and discuss that in details with him and your cardiologist.
Yes, excuse me, this is Mohammed Al-Shaidan. I just want to give a comment here. Most of the data on rheumatic mitral repair come from Thailand and from Asia, because these people have a lot of rheumatic valve problem. I trained with Vinay Badwar, which one of the big names in mitral valve repair and rheumatic in the States. I think it's very difficult to generalize that 70% successful rate. This is in very highly experienced hand and in a center of excellence in mitral valve repair. And I would say the repair of rheumatic mitral valve depends on multiple factors. Depends on the mobility of anterior leaflets, the degree of subvalvular apparatus involvement, the degree of calcifications, Wilson score. All this play a role in rheumatic mitral valve repair, and also the technique you use. Some people they do anterior valve extension, some people use posterior valve extension, some people do both, some people use rings, some do not. So it depends on the expertise of the center. But I would say, as a young surgeon, we have to be careful about repairing a rheumatic mitral valve and ended up with a very early failure. Thank you.
Okay, I'll proceed with the second lesion, which is rheumatic mitral stenosis with rheumatic aortic stenosis. The pathology behind that, we have mitral stenosis and aortic stenosis. The bad thing here with the pressure, left ventricle pressure overload, which ventricular hypertrophy will develop, and also diastolic dysfunction will occur just due to aortic stenosis. And we will have a small, as we see here, small cavity, left ventricle cavity, and non-compliant left ventricle also. All that will combination with the mitral stenosis will decrease the cardiac output. and will elevate also the left atrial and pulmonary artery pressure. And for operative decision making, prosthesis replacement for we have to replace either mechanical or tissue valve. With mild AS, we will just careful follow-up. We will not replace the aortic, although 50% will develop the moderate to severe after 15 years. And there is a unique problem for the surgeon with the once we have a lesion of AS and MS, the left ventricle will be hypertrophied. That means the mitral orifice will be more anterior, so the exposure will be poor, and so the incision, first incision, will make a difference in exposure, and the small LV that once we are impinging or implanting the prosthesis, the strut maybe block or obstruct the left ventricle outflow to be just take care of. Okay. The third lesion is rheumatic mitral regurg with rheumatic aortic regurg. So the pathology here, rheumatic aortic regurg with rheumatic mitral regurg. The mitral regurg, severe volume overload will be in the left ventricle due to regurgitation in both sides, with chronic volume overload in the left ventricle will increase the stroke volume, and that will distend the left ventricle more and more. But the advantage here, the large stroke volume, which we have it, that will decrease the myocardial fiber shortening. So the velocity of shortening will be higher, and that will decrease the cardiac output in combination of aortic regurg and mitral regurg, and will produce more and severe pulmonary congestion. Just a note to be taken here from aortic regurg and aortic stenosis. The patient who have a increased volume load in the left ventricle, he will respond better than the patient who can tolerate the surgical correction, better than the patient who is having hypertrophied ventricle and increase the pressure load to the left ventricle. For the, I know that this statement will be somehow annoying, but operative decision, we will replace both at the time of aortic operation. For myxomatous and prolapse valve, we are like this. We are finishing the rheumatic. I will proceed with the myxomatous and prolapsing valve disease affecting multiple valve. The epidemiology, most common etiology of MR, it's and required the surgical correction. This entity, and myxomatous aortic valve with annular dilatation is most common aortic regurg, most common cause of aortic regurg. If we have an isolated valve with this disease, myxomatous or prolapsing valve, it will not be associated with connective tissue disease, which is a systemic disease. But if we have more than one valve involved, that means we are having connective tissue disease, and we have to look at Marfan or osteogenesis imperfecta or Ehlers-Danlos syndrome or other causes. The pathophysiology of aortic regurg in Marfan, we have annular ectasia, annular aortic ectasia, which is progressing enlargement of the sinus of Alzheimer and aortic valve annulus. For the principle of MR in setting of Marfan syndrome, the mitral annular will be dilated, so it will be floppy or prolapsing leaflet, and the mitral annulus also sometimes will be calcific. The pathological lesion in Marfan, cystic medial necrosis, will causing degeneration of elastin fiber and infrequent cystine, infrequent cyst that will alter the synthesis of cellular secretion of fibrillin. So for Marfan, echo will show frequent AR prolapse with MR prolapse between 3 to 24%. And if we take a look of this table with incidence of echocardiography evidence of aortic valve prolapse in patients with mitral valve prolapse, you will have a total in prolapse will be 7%, and aortic regurg and aortic valve, aortic and mitral valve replacement will be happen 2%, but we are they are stating in other part with requiring surgical correction is 17%. So the 17% of patients with myxomatous aortic valve requiring surgical correction of mitral regurg. Operative decision making for Marfan and who have multiple valve disease. We have two conditions. Either there is no annulo aortic ectasia, that's mean he's not Marfan, or we have Marfan syndrome. If does not having annulo aortic ectasia, myxomatous degeneration with aortic regurg and mitral regurg, we will do repair both of them. Depend upon the morphology of the cusp. If the cusp strong and little prolapse, and also the prolapse is limited to, let's say, one cusp, we can repair it by either commissural narrowing or cusp resuspension. The outcome of repair, it's good in terms of patient survival and in terms of freedom from valve-related complication. Reoperation is 35% of patients in 10 years after initial procedure for repair in this setting. But if the patient having Marfan syndrome, he will require composite replacement of aortic valve and ascending aorta, and for if it's associated with the mitral regurg, we have to, we can leave the mitral regurg or fix and repair the mitral regurg by remodeling the sinus, by suspending the aortic valve inside the graft, or which is reported in 80% of patients with mitral regurg and Marfan at 5 years post-operatively. 88% of them will be free of significant mitral valve insufficiency.
Can I comment here?
Yes, please.
So again, you require replacement for the aortic valve with a composite graft for Marfan patients. and that's not it's not the current practice. At least people will disagree with that. You just mentioned something later about suspending the valve within the graft. What do you mean by that?
We can remodeling the because there is a aorto mitral continuity. So once we are putting the graft, the valve inside the graft, we can.
The valve, which valve are you talking about? The aortic valve?
Aortic.
So when you put it inside the graft, resuspending it.
Yeah, and remodeling the sinus.
What do you call this procedure?
I'm not sure.
David. Valve sparing David procedure.
Okay, and this is probably what every surgeon will strive to do, except if the valve leaflet are grossly abnormal. Grossly abnormal, I mean in particular we're talking about thickness. Otherwise, if it's thin and pliable, most of it, and even if it was regurgitant before, severe regurgitant, and you can manage to do this procedure to preserve the valve with good competency, that will be the procedure of choice. Bye. Shukran.
Like this, we are finishing the myxomatous and prolapse valve. The third lesion, it's a senile calcific aortic valve disease with multiple valve involvement. I just attached a picture of leaflet and aortic valve calcification. In senile calcific aortic stenosis usually present as an isolated lesion, but once we have a combined with the mitral, which is uncommon, sometimes it will be there. We have a pattern where the multiple valve involvement in calcific aortic stenosis. We have calcific aortic stenosis with infective endocarditis of the mitral valve, or calcific aortic stenosis with functional mitral valve, and also calcific aortic stenosis with calcification of mitral valve. The first lesion, aortic stenosis, is with the infective endocarditis in the mitral valve. Calcification of aortic stenosis with infective endocarditis of mitral valve can be it's a frequent site of infective endocarditis, where the involvement of mitral by abscess or extension or just the jet lesion to the mitral, especially the anterior leaflet, it will cause the infective endocarditis, either vegetation or perforation or even chordal disruption. And management can be by vegetation removal, and if it's perforation, can be patched if the tissue is strong and healthy. And for the calcification of aortic stenosis with functional mitral disease, the aortic mixed lesion, stenosis, and regurgitation, if that's happen, the volume load will cause left ventricle dilatation, then the secondary MR due to dilatation of the annulus with the normal structure mitral valve. And this situation, the first lesion we are speaking about in this lecture. So we are discussing before. Then the third lesion, it's calcific aortic stenosis with calcification of mitral valve. Degenerative calcification, it's in this setting usually degenerative calcification, which is age-related. And 33% of patients older than 75, they will have degenerative aortic or degenerative mitral, mitral calcification. And 25 to 50% of patients will having calcific aortic stenosis with the mitral annulus calcification. They will be elderly who have a severe AS or female gender. All of them will develop this lesion. For carcinoid heart disease affecting multiple valve,
Khalifa,
تفضل.
to the last point you mentioned, because of the senile and a very old age, a female, 75 or 70 years old. Nowadays, because of the advancement of TAVI, so those they will go for TAVI.
Yes.
They're not going for Max is different story. It's associated with, for example, mitral repair as a functional, and that affecting they can go TAVI plus mitral clip because of the advancement currently in between or interventional cardiologists and now also cardiac surgeon. They are more and more involved in both TAVI and mitral clip. Just to keep this in mind for you and for the others. Thank you.
Thank you.
Can you use the clip for MAC, mitral calcification?
No, I'm saying if there is MR, severe MR, there is criteria to be to use a clip. They need to see the mobility of the leaflet, where is the pathology, all that. I'm not, and I know something about it, but I'm not expert, and they need to see the echo, discuss it, then if it is can be done via clip or not.
Yes,
It might be an option.
Yes, Dr. Haitham. Yes, if you have the clip does not have no relation with particularly the annular calcification. As Haitham was mentioning, it is an echo guided. It depends on the leaflet mobility, leaflet height, how much is the gap between the two, and how much is the height, and how much is the tenting height, and how much is the distance between the two leaflets. These are the two. There are other echo criteria for the to apply the clip. So if you have a mitral regurgitation related with the annular calcification and leaflets are normal, they may be amenable to the clip. So, but may or may not, depending on the criteria selected on the echo.
Clear.
Khalifa?
Yes.
This is a question for you, but I think all the seniors should be aware of the answer. I don't. You can say answer yes or no. Do you know the exact pathophysiology, molecular pathology, and cellular pathology related to calcifications of the aortic leaflet, or for that matter of fact, the mitral leaflet? Yes or no?
Cellular, I don't know. No.
Okay. So the question goes to the seniors. Not, I don't expect the answer now. You should really read about it and know the exact details of the theories behind it. Thank you.
Okay. I will proceed.
Khalifa?
Anyone? تفضل.
Just a small comment for the mitral clip. I believe mitral clip is for the latest guidelines, still class 2B, for providing some condition, which is severe symptomatic mitral regurg plus a prohibitive risk for surgery, plus favorable anatomy and reasonable life expectancy. So before judging on mitral clip or not, we have to keep in mind that it's for a prohibitive risk. The first line for treatment is surgery, and the patient should be with a reasonable life expectancy. It's not a morbid patient. And the reduction of MR by 2 grades, it can reach up to 65%. So, and clinical improvement can reach up to 90%. Thank you very much.
Khalid,
تفضل.
just to clarify more, my comment was just on the context of what he mentioned, that all the senile aortic stenosis and there is associated mitral regurg, not in general, as you said.
Yes,
So,
Dr.
so to
Khalid,
finalize it, okay, ahead.
just want to, yes, Dr. Khalid, you are right, absolutely. This is a hard team decision. Here the question was, are these amenable to clip or no? Yes, they are amenable, but the decision, as you said, is the comorbidities, the prohibitive risk, other factors, hard team decision, whether we should clip or not. That leave to the hard team decision. Okay, thank you.
Yeah, exactly. Thank you very much.
And to add to that is the guidelines is, yes, coming short only for the high risk group, but the literature is changing and the current practice is also changing. They're now moving toward moderate and even lower risk patients for the TAVI. Thank you.
تفضل خليفة.
The fourth lesion, which is carcinoid heart disease, affecting multiple valve. Here the epidemiology will be 50% of patients with carcinoid tumor will 50% of patients with carcinoid tumor will having valvular disease, and more with the primary carcinoid tumor in the small intestine. If the primary site is the small intestine, it will be more to have a right ventricle disease with the tricuspid and pulmonary valve. Survival, as they stated, has been improved over the last decade after the intervention. For diagnosis and symptoms and sign, clinically, right-sided heart failure, increased JVB, right ventricle enlargement with peritoneal heave, murmur, ascites, and liver enlargement. But we have to keep in mind sometimes these symptoms is associated with the primary disease or hepatic metastasis from the disease itself, and the patient does not have right heart failure. For ECG, we will have low voltage and due to pleural effusion and right branch block and evidence of right atrial enlargement also. For X-ray, we will have cardiomegaly, pleural effusion, and thickening of the pleura also. In echo, we will see in tricuspid thickened and reduced motion. We can say fixed semi-opened valve. In the pulmonary valve, we will see thickened valve but retracted cusp and sometimes fusion and fusion of the commissure. For cardiac catheterization, it's not indicated here in the carcinoid unless the patient have an ischemic disease. For pathophysiology of carcinoid resulting from deposition of plaque on the endocardium of the valve and atria, then can be developed in the aortic and mitral position. Yes, can be, especially if the patient having intracardiac shunt, or the patient primary disease will be in the lung. For the valve damage, after exposure to substance release from carcinoid tumor, which is serotonin and bradykinin, which these two, which is usually secreted by a neuroendocrine tumor, which is carcinoid here, and usually inactivate in the lung and liver. In this schedule, we will see the tumor location. If it's in the gut, we will have right-sided plaque, and if it's in the ovary, will be systemic drainage and right-sided location or seeding site. And if it's in the bronchial or lung, we will have left-sided plaque location. So just I bring a picture of carcinoid tricuspid. The dominant functional lesion in the tricuspid will be regurg, and in the pulmonary valve it will be mixed, stenotic and also regurg. For operative decision, we will have an indication for surgery. First of all, increasing symptoms of congestive heart failure with evidence of valvular disease. This is one. And also progressive right ventricle enlargement, even if there is no symptoms. And the third one, they should control the systemic carcinoid symptoms before we are going for surgery. For a tricuspid valve, always we are going for replacement, but in this particular patient, we will go for mechanical prosthesis because the plaque can form again on the bioprosthesis. But sometimes we can go for bioprosthesis if the patient has liver dysfunction, because the anticoagulant will have issue with the warfarin during if he has a liver dysfunction. For pulmonary valve option, previously, as we mentioned, they was having only excised the valve, but nowadays they are replacing rather than excision. For the management of carcinoid, they are treated with the long-acting octreotide, which is somatostatin, and intraoperatively we are using a short-acting octreotide just before induction of anesthesia or at termination of cardiopulmonary bypass. So the two sites. And pre-operatively, we have to use steroid and antihistamine just to suppress the tumor-releasing mediator because it's associated with flush and vasodilatation. Post-operatively, we will return back to the octreotide, but we will adjust the dose according to the vasodilatation status. Like this, I finished the fourth lesion. Then the last few slides for the result of multiple valve in way of long and short-term mortality, thromboembolism, and anticoagulation, related hemorrhage, and prosthesis valve infected endocarditis, and valve performance. In long-term and short-term mortality, shown to improved with the refined or advanced myocardial protection. The mortality, it was 40% once we are depending on normothermic ischemic arrest. But nowadays with cardiologic arrest, it's decreased to 10% only. And operative mortality, 6 to 17% in the 30 days mortality or hospital mortality, and 5 years survival to 60 to 88%, and 10 years 43 to 80%. For risk factor and cause of death, risk factor: advanced NIHA class, advanced age, current or prior myocardial revascularization, low ejection fraction, presence of coronary artery disease, aortic stenosis, and elevated pulmonary artery pressure, and also TR, and diabetes mellitus. Cause of death: low cardiac output, myocardial infarction, technical failure, and multiple organ failure, ventricular rupture. This is previously, but nowadays we are preserving most of the geometry, so this cause decrease, and mechanical obstruction. For thromboembolism, 1 to 7% of 1 to 7% per patient year will have a thromboembolism. 10 years post-operatively will be freedom from thromboembolism event, range from 77 to 89%, and no significant difference, as they stated in the book. No significant difference between single valve replacement and multiple valve replacement in terms of thromboembolism. Anticoagulation related hemorrhage. It's rated in 0.2 to 2.5% per patient year, depend on the target INR. But for the valve performance, sorry, this is the anticoagulation related hemorrhage. It's rated between 0.1 to 4.5 per patient year. And for prosthesis valve infected endocarditis, 0.2 to 2.5 per patient year. And for valve performance, the bioprosthesis structural deterioration related to valve position, it's usually failed if it's early, if it's in AV, if it's in position of AV mitral position in compared to aortic position. And the rate of deterioration, as they stated, is similar to isolated mitral. And this is all. Thank you. Any question, any comment, please?
Thank you very much.
Very nice, very nice presentation.
يعطيك العافية.
Thank you. شكرا يعطيك العافية.
Good job, Khalifa.
Who's next? Amjad?
Okay, until you find the next person, Khalifa, can you tell us why the mitral is more subject for degeneration earlier, the tissue valves? You said the mitral bioprostheses have a higher rate of structural deterioration. Why?
Maybe I'm not sure the exact answer, but maybe just because the higher pressure which he faced during systole, and it is one. And
is it higher than the aortic pressure?
Aortic usually open. During it will open, the aortic pressure will open during the systole, so it will not have a resistance force, but the mitral it will have it. This is how can I understand it?
Okay, close, but you need to know exactly why the shear pressure is different between the two positions. Another thing is the bioprostheses these days have extended its time to beyond 20 years, and they even expect to have more, especially with the advances in the tissue valve of using stem cells and biogels and things like this. So you may, in your time, you may see bioprosthesis becoming more prevalent, and it's definitely having less problems with anticoagulation. There was another point I wanted to mention. Yes. So in general, from your talk, is this statement correct? That anytime we have a chance to repair the mitral valve, we should.
Sorry again, Dr. Malish.
Is this statement correct or false? Like if you have no contraindication, you should attempt always repairing the valve.
For the mitral, yes, if we have no contraindication, we should
even for the aortic, but usually aortic valve repair has higher failure rate. Another question, what are the contraindications? And this is particular for everybody, especially the juniors. What are the contraindications of repairing a mitral rheumatic heart disease, rheumatic valvular disease? Is there any specific information that's related to that?
active disease.
عفوا انا طيب
and
انا ما يمكن انت the most senior person في المجموعه ولا بس خليه هو يجاوب خليه يتعلم يلا معلش
Okay,
انا
sorry.
اترك لكم هي they should think about it and this is a question that you should know because we still have endemic problems with rheumatic heart disease. We have accumulated more than in King Faisal. When I reported this first time, it was in 1991. We had at that time more than 3,000 cases. Since then, we have doubled that number. So we have the experience of quite a large population, and we still have rheumatic heart disease from time to time. Thank you.
Dr. Farid, I just have a question for you.
No questions are allowed in front of the group.
No, not question.
No.
I just want to know, not question is like, like info. I want to know, what is the technique you used, like, repairing the rheumatic? What was a common method to repair the rheumatic valve?
Okay. We had Dr. Duran. I'm sorry, let me see here. Yes, you can hear me. We had Dr. Duran with us for about 7 years. During that time, I got the honor to learn from him many of his techniques, including his own philosophy about the rings. But as I learned a little bit more, I became very much against using the rings. So I still do my repairs with as much as possible without using a fixed ring. And I think that's better for the heart. That's my personal bias. And at one time he said, well, now we have a very good population. I think we had like a series of 200 with rings and 200 without rings. And we compared those results. And the results were comparable. More recently, there was a publication from, I think from China, but I can't remember where exactly, stating that...
Pure rheumatic.
I'm sorry, what did you say?
You are talking pure rheumatic disease, right?
Yes, correct. Yeah. So we have most of our disease here. I would say 90% of our disease is rheumatic. We do see occasionally the degenerative type in elderly patients, but that's not common. Maybe Khalid can answer to this through his experience in the last 5 years or so, and Haytham and Murtada, they can tell us what kind of mitral valve disease we have currently on stage, because I haven't done this for the last 10 years or 15 years. I deal mainly with pediatrics. Yes.
Yes, I have when I was doing, we were in India, we were repairing the mitral rheumatic. We were shaving the anterior leaflet, like, the rheumatic process, and it was becoming very pliable. This was a common technique we were doing there. Then sometimes, extension of the, as Muhammad mentioned previously, sometimes extension of the posterior leaflet or extension of the anterior leaflet. This is how, but I personally, I have no much experience. So just during my training course, I was exposed to repair a good number of rheumatic cases. Thank you.
And I use also the annular annuloplasty for the annular repair, as well as all techniques. There's a recent paper, I think maybe 2 years back or something. It talks about all the techniques that used in mitral valve repair. And I think every resident should read that, because not every patient is the same. This patient, you may use this technique and this technique, or a combination of those two techniques. There are a lot of things you can do around the mitral valve for repair. And many times you can get with very good results, durable, very good results that avoid anticoagulation for quite a long time. It becomes a question if you really have to operate on 30% of your patients after, let's say, 12, 15 years, and now we have those tissue valve that can last longer than 20 years. It's becoming now a question, should you really resist on repair? But I think repairing is, I still believe, and I think everybody should, by the current standard, that if you can repair the valve, you should continue to do so. if no contraindication. Thank you.
And you asked me, I have not that much experience. Khalid can elaborate more because he worked with Dr. Ashmeeg more than me. But for example, I saw a couple of cases with rheumatic. Some surgeon, they are attempt to repair it, but those they are experienced one, as Dr. Shaidan also was mentioned before, and there is criteria, even the literature, there is too big, from the Australia, I think, registry, the one I read it before, for repairing rheumatic valve diseases depend on the valve itself, the mobility of the leaflets, calcification on the leaflets, on the mitral valve apparatus. I noticed one of the surgeon I work with, he was trying to repair. He repaired maybe with me 2, but another 2, he examined it, then he replaced it. I noticed Dr. Ashmeeg once also he was in big favor of repair, but Khalid, he worked more with him, maybe he saw more with him regarding repair. I know that before like 20 years he was repairing a lot of mitral, but it depends on the anatomy and of the valve itself.
So a word of recognition, let's say. I think if you see a surgeon looking at the valve, examining it, and then deciding to go for replacement, he must be a wise surgeon.
Can I comment, Dr. Farid? Hello?
Go ahead. Go ahead, please.
أنا دكتور ياسر الغنيم دكتور فايد.
أهلا
أهلا
Professor.
Yeah, and I just have one odd comment because I've working with Tyrone David for more than 3 years, and we published one publication regarding the rheumatic heart disease in the immigrants in Canada. And they did like 500 cases. And as you know, Dr. David was always doing his cases by himself. And he's one of the best. And he was mainly using the rings and the artificial cordia at that time. And unfortunately, the results was very poor, and the incidence of reoperation was very high. The freedom from reoperation also. And our conclusion, honestly, was always not to try to repair the mitral rheumatic. So, my personal limited experience, I always, most of the time, go have a very low threshold for replacement in the rheumatic heart disease, not repair. I know this will be strange, but this is what I'm doing always.
Dr. Farid, can I give a comment? This is Mohammed Al-Shadan.
Yeah, Allah يحييك, تفضل.
So I did last year when I was in the States, I did 6 cases of rheumatic mitral repair. So basically, when you do these cases, I mean, in the experience and so, you have to really look at the mobility of the anterior mitral leaflet and what are the degree of the commissural fusion, because the cornerstone is to release the commissure and to make the anterior leaflet mobile. So what we did actually, we detach the anterior mitral leaflet from the annulus, and we made the posterior mitral leaflet as a bumper. So, and we took the physiosizer and we measured the anterior leaflet extension by going from the trigon to trigon and to try to make the anterior leaflet as a sail, So then we took a pericardium and we fixed it with the formaldehyde. And then we did a continuous running suture into the anterior, into the annulus. And when we sutured that to the rim of the anterior mitral leaflet, we used interlock stitch just to make sure it does not shrink. And after that, we used actually the CG Future incomplete ring from Medtronic, or the ATS also Celamus ring. So I think it's fair statement to say to repair rheumatic mitral, but as I said, it depends really on expertise, and there's a lot of judgment, because sometimes you have to release some of the secondary cords, sometimes you have to shave some of the anterior cord to make it a little bit more mobile, and to make anterior leaflet more mobile. However, the result was actually great because we follow these patients. We did pre-dismissal or 30 days echo and echo at 1 year. I don't have the data. All these 6 people, they have a good results, but I don't know. We don't have the long-term data. It's coming, but I said it's. I think, as you said, it's very rewarding if you have a patient who met the criteria of repair. But for the young people, the one who's gonna start their career soon, I would say be very low threshold to replace rather than repair if you're not really sure about the outcome. Thank you.
Nice comment, and I think it has a very good teaching point for the resident. Thank you.
Thank you. يديكم العافية. I think Amjad عبد الملك.
Yes.
Amjad هو next صح؟
Yes. Should I start?
أمجد أنت معك.
تفضل.
خد شير سكرين و